As many of you may know, value-based solutions focus on linking the cost of a drug to the health outcomes it delivers. Under the IRA, implementing value-based pricing could further drive down costs. One avenue for this is to adopt health technology assessment or HTA-like approaches, as are used in some ex-US markets, notably the UK. An emphasis on cost effectiveness and cost reduction could lead to increased reliance on ICER's assessment to determine the direct price negotiation for medications. With that said, in your opinion, Rec, can HTA-based solutions become more prominent in Medicare's direct pricing negotiations? And if yes, do you believe this will trigger the use of ICER as part of the reimbursement process?
Some of the language used in the IRA, such as terms like therapeutic advance, unmet need, therapeutic alternative, cost offsets, indeed connote to elements typically covered in health technology assessments. The definitions and potentially evolving process around therapeutic alternatives will be an important one for the industry to watch and comment on as appropriate. At this juncture, ICER performed 2 evaluations on drugs that were covered in the first negotiations, and it has been publicly reported that they have provided some ideas on the negotiation process to CMS. But to my understanding, that is the extent at the moment. It remains to be seen whether ICER will obtain a more formal role within the negotiation process, and if so, what that would entail. Certainly one to watch.
As the healthcare industry adapts to the new landscape shaped by the Inflation Reduction Act, companies will need to focus on several key strategies to navigate its consequences. Investing in value-based pricing models and demonstrating the cost-effectiveness of their product will be essential. Building robust market access and pricing strategies will help maintain competitiveness in this evolving environment. Additionally, the IRA may necessitate change in organizational structures within healthcare companies. There will likely be a greater emphasis on roles related to market access, pricing, and health economics. Strengthening capabilities in data analysis, value-based pricing, and negotiation will be vital. And as a result, roles such as health economists, pricing strategists, and market access specialists will become increasingly important to effectively navigate the new regulatory landscape. Given this significant shift, Rec, what advice would you give companies to effectively navigate the consequence of the IRA? And how do you foresee the IRA impacting the organizational structure of healthcare industry companies? And what roles will be necessary to adapt?
On navigating the consequences, I would say a few things. First, as with any economic policy or regulation, think about the incentives of the various stakeholders in light of the new regulations. More specifically and related to the pharmaceutical and biotech industry in the US, thinking carefully about which business one is in will be even more critical. Some questions that take on even more prominence than perhaps before can be the following. Are you playing in Part D or B? Are you in primary care or specialty or rare disease? Are you single source or playing in an environment with generics or pending generics? What might be considered a therapeutic alternative in the area you're working in? Which customers have large books of business in administering Medicare Advantage, either through PDPs or in MAPDs? This is not a comprehensive list, but hopefully the audience has a bit more context as to why such questions in light of the IRA are important ones to ask. As for how the IRA may impact organizational structure, I can foresee added emphasis on roles that assess the quantitative impact on portfolios as a result of the many changes, not only to ensure accurate forecasting, but also to gain sometimes what could be counterintuitive insights. It also puts added strain on healthcare policy teams, even in just keeping up with progress regarding any further regulation, but also implementation. For instance, the seamlessness of out-of-pocket smoothing implementation is currently a matter of debate. Lastly, and bigger picture, I would say the IRA is perhaps truly the change in the US that is starting to adopt some of the ex-US approaches to cost containment. even just by direct government negotiation on prices, that in and of itself is a major departure from the status quo, and as we know, a staple in many other markets. If we accept this premise, then now is the time where experts in ex-US market access can assist their US colleagues in making them aware of some of how certain policy implementations can and have played out outside of the US. While not the same, I feel this is the juncture where this US ex-US internal collaboration takes on added significance.
It is well known that innovation is a key driver of progress in healthcare. While the IRA aims to reduce healthcare costs, there are concerns about its potential impact on pharmaceutical innovation. Balancing cost reduction with the need to maintain incentives for developing new treatments is a key consideration. Reg, is there a risk that the IRA could jeopardize innovation within the healthcare sector? And if so, how can this be mitigated?
Yeah, this is arguably the most important question to ask, and so it's a good one to end on. It's highly multifactorial with many aspects that are worth discussing, but let's stay at the level of core objectives and taking a page out of how economically based incentives impact markets in general and the healthcare insurance market specifically. At a high level, what still really needs to play out are a few items. Will the 4-year difference in the exclusion period between Part D and Part B drugs stay the way it is now? And if so, will it steer innovation towards biologics and physician or healthcare practitioner administered medicines and even curb innovation? Some actual decisions today, as well as some projections from some reputable institutions, would suggest that the answer is yes. The next key question that has already been introduced in the public domain is, are the MFPs that have come out recently to go into effect in 2026 truly different and lower than the potential prices projected for 2026 that could have been anticipated and modeled in the absence of the IRA, given their competitive environments? Here I would refer your audience to have a look at the early reads that are coming out in the public domain, and for now say, let's see how it plays out over the next few years. Again, at a high level, concepts like therapeutic alternatives and how they may evolve over time or stay as they may have been applied in this first cycle can be important. As I mentioned at the outset, we should also not look at the IRA in isolation, but look comprehensively around key reforms, including PBM reform, 340B evolution, alternative payment models even, to mention just a few. So in conclusion, I hope I've been able to provide some food for thought for your audience and an appreciation for some of the fascinating complexity in the US healthcare system, highlighting the importance of keeping the patient and innovation at the center.
Thank you, Reg, for this comprehensive and insightful discussion on the IRA and its multifaceted impact on the US healthcare system. Your depth of experience and thoughtful analysis have undoubtedly provided our audience with a clear understanding of the challenges and opportunities that lie ahead.
Thank you for the kind invite, Noah, and it was my pleasure.
And to our audience, we hope that today's sessions has offered valuable perspectives and answered to some of the pressing questions surrounding this legislation. And before we conclude, I'd like to remind you to stay connected with us for future discussions and insights. Follow InSaccelerate on LinkedIn and X by scanning the QR codes displayed on your screen. Thank you, everyone, for joining us today. Until next time, take care and goodbye.